Let's move to my first project. Congenital birth defects is one of the most important dangerous cases in the newborn babies, which accounts for 1% of prevalence in newborn babies. And according to a European registration of congenital anomalies and twins, for the mothers with of the severe congenital birth defects cases, only 40% of them receive the prenatal diagnosis, and only 20% of them receive this kind of detection before the 25 weeks of gestation. And it is worth noting 10% of the birth defects cases are associated with the marginal environmental factors. So we're able to identify the marginal risk factors that are associated with congenital birth defects. Our clinical question is, what marginal environment factors are associated with the risk of the congenital birth defects? We use the PICO framework. Our populations are the pregnant women. Exposures are marginal risk factors. Comparison is the absence of the risk factors, and the outcomes are congenital birth defects. We make a hypothesis here. Some marginal factors will increase the risk of the developing congenital birth defects. Our systematic search was conducted on November 16, 2023. And our search key has been divided into 3 domains. The first domain is the pregnant women and its synonyms. The second domain is the risk factors and marginal exposures. The last domain is congenital birth defects and 10 of the most common phenotypes. After 2 cycles of selection, we've got 2 cycles of selection. We've got 59 eligible articles from the systematic search and full text screening. Additionally, we've got 19 additional articles from the reference treatment. Finally, we've got 78 articles in total. Due to time limits, I will show you 2 of the important and interesting figures in my project. As you can see, this figure shows the association between the maternal diabetes and the congenital birth defects. The pre-pregnancy diabetes is defined as a chronic diabetes, and it happened before the pregnancy, and it was always diagnosed by the OGTT test and fasting plasma glucose test. And it's worth noting that some of the studies, they also use the self-reporting data in their cohort or in their population from the mothers and from the medical reports. We've included 21 studies in here, and all of them are case control studies or cohort studies. The I-square equals to 87, which indicates the high heterogeneity of the analysis. So the odds ratio is 2.91, which is significant, which has a statistical significance and clinical relevance. This result suggests that the mothers with the pre-pregnancy diabetes for their babies have near three-fourths of the increased risk to having the congenital birth defects compared with the mothers with the normal glycemic level. As the second figure is the association between the marginal smoking and the congenital birth defects. The marginal smoking means the smoking during the first trimester, and this data was collected from the self-reporting data. We included 19 studies in this forest plot, and all of these studies are case control studies or cohort studies. The I-square equal to 83, which indicates the high heterogeneity of the analysis. The odds ratio is 1.28, which indicates which means the statistically significance and the clinically relevance. So this result suggests that the mothers smoking during the first trimester will increase the risk of the congenital birth defects by 28%. Of course, we have some strengths and limitations in this project. So our strategy is to analyze the six marginal risk factors across the overall and the specific congenital birth defects. phenotypes. And also we include the chronic disease and the nutrition status as the risk factors. And also we use a very innovative analysis, subgroup analysis based on our risk of bias level. And some limitations should be focused on. The first one is the inconsistent of the cutoff values in some risk factors. And second one is the required information bias from self-reporting data, for example, smoking, alcohol, and diabetes. And last but not least, uncontrolled confounders in some studies should be paid attention. In summary, diabetes, obesity, smoking, and chronic hypertension were found to be the critical marginal risk factors for congenital defects in offspring during the first trimester of the pregnancy. This project may contribute to the pre-pregnancy counseling and pregnancy care, and also we highly suggest that in the future study should investigate the treated and untreated disease on the effects on their offspring, and also conduct a population-based study to investigate the impact of demographic factors on the relationship between the marginal factors and congenital defects. Currently, we submit our article to the manuscript to the Frontiers of Medicine, which is the Q1 journal, and is under review now. The second project is a case control study on investigating the association between the marginal risk factors and congenital defects. As far as I know, many population-based studies, cohort studies or case control studies in this topic, some common marginal risk factors, for example, the marginal diseases, smoking, alcohol consumption, and medication use, they are involved in these projects. However, most of the studies they examine only one marginal factors or the congenital types. They're lacking the comprehensive registry-based analysis. So we aim to conduct a nationwide population-based case control study to examine the effect of the survival of the several marginal risk factors on congenital defects. Our clinical question is, do some marginal risk factors increase the incidence of congenital defects? Our populations are mothers with their paired singleton births, and our exposures is the presence of the marginal risk factors. Our outcomes is incidence of congenital defects. We make a hypothesis here. Some marginal risk factors will increase the incidence of the congenital defects. We include singleton births with marginal linkage, which includes the live births, stillbirths, and terminated pregnancies, and also diagnosed congenital defect cases with common phenotypes, which includes both isolated one and combined defects. We exclude the twin or multiple births or only the non-congenital defects. We use the patient registry from the Hungarian case control surveillance of the congenital anomalies, which from 1980 to 2009. We would like to analyze here are some key variables here. For example, the marginal characteristics, infant characteristics, and of course the diagnosis of the congenital defects, and also marginal exposures and conditions. Currently, we are in the second round of the data cleansing. In summary, we have two specific goals and currently project ongoing. In these 2 years, I work as a co-investigators in the first 1 year student Miao Xinhuang's systematic and meta-analysis project, and also I am very honored to be assistant to translate the Chinese articles to our students and help them in their projects. The last but not least, I will be the presenter in the conference presentation in the Spring Week conference. Thank you very much. He was of an active nature and yet fond of learning, and he was not ashamed to act and learn of his infernals. Thank you very much for your attention.
So congratulations, Zihan. It was very nice. And I'm really curious about the risk of bias level subgroup analysis. So why do you prefer to do the subgroup analysis based on the risk of bias levels?
Yes, thank you for your question. So, I think you should focus, consider why the heterogeneity is so high in my analysis. So I'm also very interested on it. So I think it should be related to the data quality. So I use the risk of bias assessment as a subgroup strategy to do the analysis. However, in my results, I found there's no significant change on the heterogeneity based on the subgroup analysis result. For example, even if we use the low level of the risk of bias group, they also have the high level of the heterogeneity in their subgroups results. So this result suggests us the heterogeneity may not because of the study quality, and this may because of the different definitions of the risk factors and also the population characteristics of the population. So yes, and some unknown confounders based in different studies. So I just want to convince my project is stable and robustness. Yeah, that's it.
Congratulations, Zihan. For me, it was not absolutely clear the definitions. For example, maternal risk factors for what? For maternal health, for fetal health, for risk of so this is quite general, and I hope that I followed well your presentation. So finally, it turned out that you identified 6 different maternal risk factors. You presented only 2: the pre-pregnancy diabetes and smoking. Yeah. What happened with the other 4? So what were these? Probably obesity, hypertension, alcohol consumption, yes. And what was the 6th? Because you presented on a slide 6 maternal risk factors.
Yes, and hypertension, right?
So again?
So obesity, diabetes, smoking, alcohol consumption, yes, and hypertension, and
6th. Okay, no problem. No problem. So it turned out that smoking and pre-pregnancy diabetes was associated with a higher risk of congenital heart disease.
Yes.
But the others did not associate it, or the other risk factors.
The alcohol consumption is not related.
Yeah. Okay. Thank you.
And the chronic hypertension, yes, and also you can see.
Why? Oh, yes. So sorry. Why you decided not to show us these results?
Yeah, because of the time limit. If I have 20 minutes, I can show all the results I can see. I would like to show all the results, but however, I only have 10 minutes, but I have two projects.
Oh my God. Oh my God.
So sorry, it's my fault. But,
no.
Yeah, so,
I thought there is a concept behind to select from the 6 results 2 results and to share with us. For any motivation, I don't know what.
And I have to say, another risk factor is underweight. So I divided BMI and 2 factors: the obesity and the underweight. So obesity, underweight, diabetes, smoking, alcohol consumption, and hypertension. So it's 6.
What was the 6th?
So underweight.
Underweight. Okay, great.
So it's my fault. I just
no fault. I thought there is a concept behind just to share only 2.
Yes, I really thank you for the suggestion, but you know the time is very short. So,
okay.
So I really want to share all my manuscript. Do you know how many words in my manuscript?
No idea. Please share the other.
1,000 words. So I have 47 supplementary pages for the supplementary because I have so many results. So I'm so sorry. Unfortunately, I really can't.
No problem. Okay, thank you.
I have a tricky question. You in your study, you're providing information on predictive risk factors, right? So you have risk factors, and they will elevate the risk for the endpoint. The strongest one that you presented was diabetes, with an odds ratio of 3.
Yes.
So what would that mean with respect to your endpoint? How would that influence that endpoint?
So in my study, I think the endpoint should be it's not very hard endpoint such as the overall survival or any other endpoint. So I think in my study, for now, the endpoint is the incidence of congenital defects. We didn't investigate the death or the complications of the congenital defect in the future. So only in this stage we will only investigate the incidence. So this result just suggests that mothers with chronic hypertension, chronic diabetes, yes, especially we set the criteria in the first trimester. Okay, so they have a near 3 times increased risk of their babies will have the congenital defect.
And what is the risk without? What is the rate without the risk factor? The prevalence of CHDs.
The rate.
How often does it occur? You showed it on the first slide. The baseline risk.
It should be the. You mean the?
It's about 1%.
Yeah, 1%. Yeah.
So you have a predictive risk factor with a 3-fold risk that would end up the outcome. How would it influence the outcome? You would expect it to occur how often?
Sorry.
3%, right? So you have a 1%, you have a three-fold risk factor, existing diabetes, and then you would have an outcome expected to occur in 3%. So exactly, three times. 3 times 1 is 3. So you would end up with 3% of babies with defects. So how would that influence your management? How would you monitor or treat pregnant women differently when they have a risk of 3% compared to 1%? How would that change your management?
Well, I think this one also the conclusion from my study, right? So yes, we can give some suggestions to the future management on the diabetes patients, or especially for the diabetes mothers. For example, the insulin treatment or any other treatment. Of course, yes. But however, we don't know such treatment will also increase the risk of the congenital defect. So for now, I can't give you a concrete management strategy for this one. We can only say that the diabetes women, they need to, or the mothers, they need to receive the frequent prenatal diagnosis and some screening techniques during the pregnancy stage. And if we would like to know how do we manage this, so we need to do the case control study or cohort study, as I mentioned in my project. So we need to know the untreated diabetes, the risk of the untreated diabetes and the risk of the treated diabetes, and also the impact of this treatment. So we need to isolate this effect, so that we can give the exact management strategies or suggestions. That's it. So for this stage, I only can say diabetes women should receive the frequent checks or the screenings. That's it.
Is this in Austria the practice? It would be very
exactly. That is the main problem. That's where I want to end up.
Share with us.
And that when you have predictive risk factors, it's interesting, but it's very hard that predictive risk factors will change your clinical management, because they have to be really substantial to change your clinical management. If your prevalence of any disease is 1% and it sums up to be 1.5 or 2 or 3%, it's still extremely rare. So the number needed to treat, the number needed to screen is extremely high. You would have to have a lot of effort to find this single more case. So that is a bit the tricky thing and the problem with predictive risk factors, that very hardly, very rarely they will change your clinical management. But
Thank you.
So I want to say, yes, so also in the Hungarian databases, as you can see, I'm doing the case control study. When I'm doing the data cleansing, so I found that there are very few cases on the diabetes. That's the reason, so it's very hard to investigate because it's really rare in Hungary and also in Austria, as you see.
Yeah, just a housekeeping. So I'm supposed to ask a question of each of them. So I thought it would be automatic, and I missed the last one. But please give it to me at the end. Yeah. So you mentioned confounders a couple of times as a limitation for the first project, and as a motivation for the second one. So what are confounders, and which ones do you think are important in this context?
Well, you mean the first one?
I guess both, but maybe the first one because that's your complete project.
Sure. So the confounders, I think it's also the most important limitation in my project. So I think the confounders, for example, some unknown confounders, for example, the population characteristics and such demographic factors and so on. That should be the very common one in some studies. And also, I think the confounders should come from the interaction between the obesity and diabetes. For example, some obesity women, they usually have the diabetes. So that should have some association between this. But we couldn't find anything. We couldn't do anything about that because in some study, in some case control study or control study, they will have the group of both have the obesity and diabetes, and also the non-diabetes and the obesity and the non-obesity and diabetes. But however, in this meta-analysis, we couldn't investigate the effect of this kind of interaction. Yes, and also the confounders. I think I mean for some hypertension defects, hypertension disease. So for some treatments, we don't know that. So, but in this project, I prefer to use the untreated hypertension disease as the risk factors. So it's much easier to control the confounders. That's it.
I just one more question to follow that up, because that is a very important question that if may ask with respect to confounders, and that's kind of a general concept for all of the studies we are going to see. One of the probably strongest confounders in your project is genetic information, right? Hereditary risk factors that could genetics.
We exclude that.
Yeah, but that was exactly my question. How could it identify that? How was this information provided in the studies? Was there in all of the studies that you've selected for your project, were there information if that has been kind of ruled out, or was that missing in some studies? And if so, which I would guess, in how many studies was this information on genetic risk factors or genetic information about the parents missing?
So I think it should be the very basic principle question in my project, because we exclude all the genetic factors. Because when you doing the observational studies on the risk factors on anything else, we don't usually to investigate the genetic ones, because it has so many changes in the study design. So actually, I didn't really concern about this genetic information because we're not interested on this. So unfortunately, yes, we exclude all the genetic types and also the syndrome types. Yeah. So I'm sorry, but that is the criteria.